Hello, welcome. Yesterday, the number of deaths from COVID-19 shot above 3,000. That's more than the number on 9/11. But as we speak, the FDA is meeting and deciding the fate of the very first COVID vaccine for this country, the one from Pfizer Biotech. The decision on Moderna will come on December 17th, hopefully, and AstraZeneca and J&J will follow shortly. These vaccines are already paid for by the federal government, and with these approvals, the government can start shipping and distributing these life-saving vaccines. Hello, my name is Anna Bob. I'm the health director at the Philanthropy Roundtable, and I'm here to celebrate with you today because this is really a day of celebration for the country and the world. This is a day that provides a way out of this deadly pandemic. There's something more here to celebrate too. This has been the fastest vaccine approval in history. The prior record was about 4 years, and before that, it was decades before we got vaccines. With us today to discuss this historic achievement are two distinguished physician scientists and policy experts. Our guests are Dr. Fred Sanfilippo, who's an MD PhD and the director of the Emory Georgia Tech Healthcare Innovation Program, a professor of pathology and health policy and management at Emory, and the medical director of the Marcus Foundation, and Bernie Marcus's chief medical advisor. Prior to this, Dr. Sanfilippo served at Johns Hopkins as pathology chair. He was the research director of the Comprehensive Transplant Center. He ran the health system at Ohio State as its CEO of the OSU Medical Center. He held many other leadership positions there. He has just a very distinguished record. He served on the editorial board of 13 professional journals and has been invited to speak at some 200 academic and scientific venues, as well as being the president of 7 academic and professional organizations and consulting to dozens and dozens and scores of government, university, and corporate institutions. Dr. Sanfilippo, thank you for joining us today.
Well, it's great to be here, but as my dad always reminded me, that and a token will get you on the subway. Back in the days when I was a kid in Queens and you used tokens. So
Well,
thank you for that kind introduction.
we're also joined by Dr. Mark McClellan, who is also a MD PhD, where they're known as mudfuds in in our world, and he's the Robert J. Margolis Professor of Business Medicine and Health Policy and the founding director of the Duke Margolis Center for Health Policy at Duke University.
Good to be
Dr.
with you all. Thank you.
Thank you, Mark. He's also, as many of us know, the former administrator at the Centers for Medicare and Medicaid Services, and he was the head of the FDA. So let me just frame our discussion a little bit today. We want to talk today first in a very practical way about what we've learned about COVID over these past months that we've all been in our homes, and how we can all survive just the next few months until each of us can get our needed vaccine shot. And then we want to talk about the work that's been done over this past several months on treatments, and then really focus as well on this historic vaccine. And then we want to reflect on what we've learned through this process, and from this really unprecedented pace of change that's occurred here. And what are the lessons for philanthropy? So with that, let's jump in to start right away talking about this deadly disease and how we can diagnose it. Dr. Sanfilippo, can you describe to us how a COVID infection causes disease and how an infected individual may respond to it?
Well, sure. And those are two great questions for a pathologist and immunologist. Basically, COVID acts like other viruses. It will infect cells, reproduce, and cause inflammatory responses. And the host response really varies tremendously based on the immunity and the immune system of that host. So in some individuals, they're what we call their innate immunity, their guard immunity can block infection. In most cases, if the virus takes hold, you will get a response that's targeted against some of the viral antigens. When the virus infects a cell, it can cause damage to the cell, and that can cause inflammation. And sometimes that can cause an immune response as well that can lead to an autoimmune response. So It's a very complicated system, but over the last number of months, we've learned a lot about the disease and also about the immune response to the disease. So clearly, we know that in many individuals, they're asymptomatic. And we know that from other types of infections as well, viral infections. I think flu is a good example, where for a variety of reasons, host immunity prevents binding of the virus or blocks the virus, or just the damage from the virus is absolutely benign. But unfortunately, that's a very high percent of those who are infected with the virus, as we well know. But for others, the damage caused by the cells, and the virus tends to infect what are called vascular endothelial cells to a large extent. Those are cells that line the blood vessels, and especially small blood vessels. And that can cause, from the damage of the infection itself, inflammation and coagulation. That's one of the responses you can get when you have damage to vascular endothelial cells, coagulation. And we know that's a major problem in terms of the lung disease, but also what we're seeing in other organ systems as well. Lung is the most obvious, but we also see that as a problem in the heart and the GI system. Some evidence certainly in the brain. And so that can be part of the response. And the other response can be the what you would call the adaptive immune response, the immune response that is really targeted against the virus and the viral antigens that are expressed. And again, that can vary tremendously and can either lead to protection and remove the disease, if you will, in the virus. It can stabilize it, or it can cause even worse disease in terms of that immune response. I think one thing you really have to understand is why disease is so variable with infectious
Yes.
organisms. And that's because the immune system is so variable. It's really unique for each one of us. We each have, in a sense, a unique immune response. And that's because the immune response we each have is based, if you want to lump in a sense, on the genetics. You inherit a lot of the immunity that you ultimately will express, but your exposure to antigens right from the time you're a fetus through birth and through all your environmental exposures, that's what really develops the immune system. So between the genetics and that exposure, everybody has a pretty unique immune response. And lastly, and as we all have come to appreciate, age is an important factor.
Yeah.
And the immune system ages just like other systems in the body. And unfortunately, as one gets older, the precision in being able to develop a very targeted, strong immune response to specific antigens in most folks wanes. And
Mm.
so we think that's a pretty significant reason for the very high risk that we're seeing for severe disease in the elderly. Again, not much of a surprise. So again, because of the immune response and the way this virus infects, we see a large number, fortunately, who are asymptomatic. We see a number who have very acute disease, and that typically involves the lung, but also involves the heart, GI system, and others. And then, depending on the nature of the immune response and the way the virus will damage and move to different organs, we can see chronic disease and the
Yeah.
so-called long hauler disease and
Yep.
some of the diseases we see in children as well.
Yeah. Um, we see surging caseloads all over the news. Could you give some advice to the people on our call to help them understand their own risk of getting COVID, as well as anything they can do to mitigate that risk?
Sure. Well, there are a couple of types of risk. One is the risk of being infected per se, and I think we all understand distancing, masks, and so on are very important in mitigating that risk of being infected. But the other risk factor is if you are infected, what's your risk of having severe disease or dying? And as I mentioned earlier, we all know a compromised immune system is a very high risk. And so that includes the age and, frankly, those who are on immunosuppressive therapies, cancer patients, transplant patients, and so on. And we also know those that have certain comorbidities where they already have underlying damage to organs, for instance. So those with cardiovascular disease or hypertension or diabetes, especially those who are at risk for developing coagulopathies, increased coagulation within the in vessels, they are at increased risk. We have learned that, no surprise, we know this, those who are at risk with a variety of social determinants, in particular access to healthcare, they are at risk and greater risk for death as well. So, uh, how to prevent infection is the first line. If you are infected, getting care early, early intervention is absolutely critical. And hopefully you're not in one of those high risk categories.
Dr. McClellan, I want to turn to you now. One of our challenges as a country in reducing infections and also in getting our country back to work has been accessing enough tests as well as accessing the right tests. How is this going?
Well, it's going better than it was. This virus has been really challenging on multiple levels. Fred talked about a couple of critical ones. One is that this is airborne, so it's pretty contagious, and required a lot of steps to try to manage that. Second is that it has at least these heterogeneous responses due to immune mediation. Most people recovering even at older ages without any serious issues, but a significant number, especially as you get older, having very serious immune overreaction, really leading to fatal or other serious complications. And then so much of the transmission is asymptomatic. At this
Mm,
point, probably more than half of cases are coming through asymptomatic transmission, particularly at younger, in young in children and in young adults, even at older ages too. And that's what has made testing so important, not just testing for people who have symptoms to know whether they've got COVID and need to take isolation steps and have contact tracing. But as we found in the early stages of the pandemic, when we didn't have any testing in place, a lot of community spread could occur without even knowing about it. So we've made progress in testing in two regards. One is the kind of more traditional type of diagnostic testing that's usually done with the lab tests, so-called PCR tests that are very accurate, very specific, don't get it wrong very often, but require sending a sample from either the nose, nasopharyngeal, anterior nares, or spit, depending on the technology, sending it off to a lab, having the lab run the test. That was the main kind of testing that was available in the spring into the summer. And you all may recall we had some big backlogs, which made it hard to contain outbreaks that were occurring. Well, as the pandemic went on into the spring and summer, it became clear that we weren't going to contain it just by focusing on people who were symptomatic. We needed to do screening, especially in areas where people had to be close together, nursing homes, other congregate living facilities, essential workplaces, et cetera. And we started trying to do screening tests in those contexts, and that really overwhelmed our lab testing system. So over time, we've seen some tremendous innovation in so-called point of care tests,
mhm.
tests like people are familiar with for rapid tests for the flu, for HIV now, for pregnancy, even, that are becoming more widely available. These tests are generally not as sensitive as the lab test, but they're quite good for detecting people who are actually infectious, and they're very good if they're used on a regular basis for screening. So you may not get an infection, you might not pick up a new infection in a nursing home worker, on day one, but if you test again a couple of days later, you'll probably detect an outbreak a lot sooner than you would if you just waited for someone to develop symptoms. It does mean you need to use these tests regularly. It does mean some issues to deal with around getting a testing system implemented, around dealing with so called false positive tests. When you're screening a bunch of people, even if the test is pretty accurate, a decent number of them are going to turn out to be people who weren't really infected. So you need to have a follow up process for that. And we've been working to get those systems in place, first in the highest risk settings like nursing homes, and now increasingly those are being rolled out into other settings, essential workplaces, schools, first responders. And we're on track to potentially have as many as 200 million or 300 million tests per month available in the first quarter of 2021, which could really help reopen schools and help contain outbreaks, which are still, as you said, a very serious problem now with the big surges. And I think this is eventually, Anna, going to turn into tests that get easier and easier to use, including tests that can be available at home. So we've seen a lot of innovation. In fact, FDA approved yesterday the first test that could be used without a prescription by someone at home. It's still not that cheap. It's still not that easy to
Yeah.
use. You have to send that one in, but we're not that far off, maybe a matter of months from tests that we'll be able to use easily and pretty reliably at home. And this is going to have a further impact in containing COVID, but also means maybe a different way of approaching infectious diseases like the flu and whatever pandemic comes along next down the line.
I love that. Yeah, that's a great innovation. So I'm going to change the subject a little bit to come to the kind of the issue of the day. I'm going to talk about vaccines for a minute. The World Health Organization had, about 100 vaccines that were in development, and then what we did in the U.S. is we winnowed this list to a dozen or so of the most promising, and then government and industry and really philanthropy as well partnered, and in some cases still stimulated competition, but in many cases collaborated in unprecedented ways to develop these vaccines and to do it fast. I mean, fast. Last I heard, there were three companies that had announced highly impressive results and also had plans for manufacturing and distribution. And of course, that was all planned with huge, billion-dollar grants from the government. That's the Pfizer BioNTech, the Moderna, and then the AstraZeneca Oxford vaccine. And J&J is not far behind. Dr. Sanfilippo, many of these vaccines use different methodologies. Can you give us a thumbnail sketch of the various types and also how effective they are?
Well, one of the as you mentioned, one of the great silver linings behind this terrible pandemic has been the ability to develop vaccines so much more quickly than we've been able to in the past. Um, Vaccines in general are products where you try to generate a protective immune response, ideally neutralizing antibodies and T cells that will respond to the virus to protect the individual or even mitigate disease in the early onset. And there are really two general categories. One is the traditional one where you use a virus, either what's called an attenuated form of the virus or a different recombinant carrier virus that's benign to produce viral antigens. Inject that, you get that virus to produce antigens. The virus is benign, doesn't cause disease and so on, other than mild inflammatory reaction. And the host then will respond to the viral antigens that are produced by those recombinant carrier viruses. In the case of AstraZeneca, it's an adenovirus that carries the viral antigens. What has been unique here is now we have, we'll hear sometime in the next hour or two, a different model for generating a protective immune response. And that is directly injecting, in a sense, the genetic code, the messenger RNA, into the host that programs the antigens to which you want that host, the viral antigens to which you want to make that host respond to. Injected in the muscle, the cells will produce the host cells will produce the antigen, and you will respond to the antigen there. And that's the Pfizer and Moderna methodologies. So again, there's, as you alluded to, there are a lot of different vaccines in development. But if you wanted to generalize, those are the different platforms that are being used. And what's new here is the mRNA platform. Very exciting.
Very excited. And from what I understand, this platform was actually developed in a lab before we even had our first death in the United States. So everything we've been doing for the last year has really been clinical trials and manufacturing and distribution plans. Is that how you would characterize it?
Yeah. I think for the Zika virus, an mRNA approach was found. The trials were not done through phase 3, certainly, but the technology was there. And so we were able to respond very quickly to COVID and be able to develop this because the genetic information was identified very early that coded for the various spike proteins. And that's one of the subtle differences. I mean, these viruses, again, have different antigens to which the host responds. And so the trick is no matter what platform you use, what specific target antigens are you stimulating against? Very analogous to passively transferring antibodies, as we've seen with other therapeutic modalities. And hopefully, we won't see the mutation effect of this virus change its stripes so that the immunization we have to the targets that have come from the vaccines that have been developed will no longer be the target of the next wave of infection.
This is a question that I received from an audience member that I'm going to just throw in here in our vaccine section. And either of you who can take it, but the COVID vaccine has been developed by private for profit pharmaceutical companies. Does that mean that philanthropy has not played a role?
Well, philanthropy, Mark, do you want to take this? But I think philanthropy's played a role. But
Yeah, it's played a role. I mean, this that while the vaccine was developed with private sector support, the initial technology development has been kind of around in a limited form for a decade plus. Came out of research funded by the government, Defense Department, and the like around some advanced new technologies. And you're right that most of the development of the vaccine has been uh, privately funded. Moderna had some joint support and is jointly developed by NIH. You know that the getting from identifying the virus and its genetic sequence into phase 1 testing in people in 2 months happened with Moderna in a collaboration with NIH. And I think going forward, there is going to be increasingly important role for philanthropies to play, both in helping to make sure the vaccine is widely available and distributing it. So the Gates Foundation is playing a huge role right now, for
Yep.
example, in helping with global supply and distribution.
Yeah, they just made an announcement today. They just committed an additional $250 million for equitable distribution of the vaccines, which is fantastic. And I would add this. I don't know if this is if you would agree, but I mean this platform technology with this mRNA vaccine because it's a platform technology, it vastly brings down the cost of responding to a new virus. So I don't know what the cost is, but I mean, obviously it's astronomical what the pharmaceutical companies have to spend. But could this bring down the cost enough that it could be within the reach of philanthropy, like in the 30 million, $40 million range? To if we have another new virus that comes and that we
I think
want
if
to
there's
use.
another new virus, it probably will again be a public-private collaboration, private companies helping to develop public support and potentially a role for philanthropy and some of the early stage research, and again in the distribution. What I think we really lucked out as a planet in this pandemic is that it occurred for the first time. We've had a pandemic in the age of synthetic biology, where in a matter of weeks to months, we've been able to manufacture essentially rapidly and at large scale a vaccine or set of vaccines that look like they're going to work. That's not to say the other platforms aren't still really good, and we can maybe come back to those. They have some
Yep.
important advantages too, and it's good to have multiple options. But not just for vaccines. We might talk about therapeutics in a little
Sure.
while, but the manufacturing of synthetic man-made versions of the antibodies, the monoclonal antibodies, also reflecting recent innovations in immunology and synthetic biology, has tremendous potential both for this pandemic and especially if we can ramp up supplies, being ready for future pandemics. So from now on, I think you're going to see very rapid diagnostic capabilities for future pathogens, and then following this playbook, developing synthetic antibodies, developing vaccines more rapidly through multiple platforms, so that hopefully we will be able to do better on the next one. I think it's still going to be a big enough deal that we're going to want the public and private sectors to
Of
all pull
course.
together, but it's
Yeah.
overall good news for the future.
Good. Well, I want to move on to therapeutics, like you mentioned, but I do want to just before we leave vaccines, I want to touch on distribution. And Dr. McClellan, perhaps you can help us understand. I've heard, perhaps by May or June, everyone could be immunized. Is that a pipe dream or is that realistic?
Well, probably not everyone, but certainly enough Americans to make a huge difference in the impact of the pandemic. And you mentioned today, big event with the FDA advisory committee reviewing kind of all the details from FDA's critique of this first application from Pfizer and BioNTech. Next week, similar kind of thing is going to happen for Moderna. Those vaccines look like they're on course for very rapid approval in the emergency use authorization process. Some people are talking today. I think if it doesn't seem like there are any big bumps on the path to authorization happening at the committee meeting today, but in any case, it will happen very soon. We don't have enough supply right away for vaccinating all Americans, so it's going to be sequential over the next few weeks with the immediate distribution coming to all the states. They've already allocated, governors have already taken their state allocations and told
Yeah.
the federal government where they want the supplies to go. It's going to go to healthcare workers and to nursing homes. And the federal government for this first phase has a very hands-on approach,
Mhm.
overseeing distribution and working with CVS and Walgreens to
Yep.
do kind of in a box vaccinations, both the first round and then the second round for nursing homes. There are about 23, 24 million frontline healthcare workers, or 21 million frontline healthcare workers, and 3 million or so workers and residents in nursing facilities. We may be able to get 20 million people vaccinated this month. That's going to be a big lift, but millions in any case. And so on into January, probably be vaccinating the rest of that group. In January, I'd expect another 20, 30 million Americans to be vaccinated using these two vaccines, assuming they're approved. By February or so, that's when the J&J vaccine could become available. Maybe 30 million more doses then. And then by March, April, maybe some of the other vaccines coming online and broader availability. But keep in mind, this is going to be sequential. So after we get past this first phase of vaccination, very tightly controlled by the government,
Yeah.
the next priority is going to be some combination of people who are at higher risk, the elderly, people with comorbidities, other individuals who are in risk categories, and frontline workers, essential workers in lots of different areas, potentially teachers, food processing workers, others who are on the front line. That's another 100 million Americans. So
Mhm.
that group is going to be the main goal for the next couple of months or so.
Mhm.
After that is when I think you'd start seeing more Americans having access, and that could be as soon as the March, April timeframe. That doesn't mean we're all done. We're,
Mhm.
as you pointed out at the beginning, this is a really, really tough phase, surge on surge in the pandemic that we're in
Mhm.
right now. That's going to go on for a while. Even after people get vaccinated, we don't know yet whether the vaccines not only protect you against getting serious complications, but make it so that you aren't able to transmit the virus anymore. It's
Okay.
possible that's the case, but until we know for sure, even if you get vaccinated, you're still going to have to wear a mask, still going to have to distance, and we need it both for mainly for protecting everybody else. So that's going to go on for a while longer, but we should see, as higher risk individuals get vaccinated, as we use some of the especially monoclonal therapies,
Mhm.
those hospitalization rates start to come down and not go back up again if we do this right. And then as we head on in towards the summer, most Americans will have had a chance to be vaccinated by then, and that's when you can really think about things getting much more back towards a semblance of normal.
That's great. Yeah, and I mean, I think a large federal role, but also a huge. I mean, I've talked to friends who are working in hospitals. Some of the academic medical centers have already, gotten their plans. And what's so
Yeah,
remarkable about this is that, I mean, they're even kind of, having to plan shifts for how people get the vaccine, because you can't have all your essential health workers sick at the same time. There's a small,
yeah,
the vaccine causes a small reaction right after you get it, and so
yeah,
I mean, there's both a huge federal push, and then there's also this huge, kind of local coordination that's going on, and those plans are already underway. And just
yeah,
the logistical um, feat that's been pulled off. Some people point to sort of this general
Yeah.
who's worked in logistics in
Yeah.
the
Well,
army and has pulled off this just incredible logistical feat planning this whole distribution.
yeah, but just to be clear, we are not done. So
No,
we
no.
are
Yeah.
now at a point where, like you said, this is a
Yep.
day that probably is
No.
worth celebrating, but it's also a day when we need to re-energize ourselves, uh, both to get through this very big surge and to do the very hard work of distribution and equitable access that lie ahead. So this first round, the government's done a really extraordinary job of putting
Yep.
together sort of the end-to-end logistics and working with healthcare organizations that are, prioritizing their own workers. After that, it's going to get more challenging. We're going to have to rely on vaccination events and outreach in communities. We're going to have to rely on our healthcare providers, and these are vaccines that are not that easy to use. The first round, with the cold storage, the need for 2 doses, tracking all of that. So there are new IT systems that are being implemented to support that. I guarantee you, having worked in the federal government on some big new IT projects, something is going to go wrong with that. There are big issues around vaccine hesitancy and people
Yes.
not sure about, given how fast this process went. I'm confident about it, but
Yep.
we've got some work to do there. There are huge roles, I think, for philanthropy to help in this whole process so that we
Yeah.
end up with equitable distribution. And for those of you who are interested, Duke Margolis, our program, just released a comprehensive report yesterday on all of the state and jurisdictional plans across the country. Everything that we summarized, reviewed, everything, all these big issues that they're having to deal with around education, outreach, and engagement, around IT systems, around distribution, around prioritization. The states have to fill in the detailed guidance here. There are a lot of things to still be worried about to make sure
Mhm.
this comes off in a way that's effective and equitable. That report's online. If you just do Duke Margolis equitable vaccine distribution or something like that, you'll find it. But we've got a lot of work to do in collaboration with states, local governments, local leaders, et cetera, for this to actually succeed.
We will post that report as well on our website. Thank you for mentioning that. And it does sound like philanthropy could potentially have a huge role to come
Yeah.
in, especially with some of the outreach we need to get done.
Yeah. Never done anything like this in the United States.
Yeah.
Mm-mm. Um, well, so I think we've alluded a couple of times to therapeutics. There's also that's also an area where there's been huge development over this past year. Dr. McClellan, I'll just frame it like this. When President Trump got sick, we learned that in addition to a bunch of vitamins and minerals that they were giving him, he was given three main treatments. He was given the steroid dexamethasone. He was given the intravenous drug remdesivir that was also used for Ebola. He was also given a Regeneron's monoclonal antibody. So these treatments got testing in emergency use for COVID. Some of
Mhm.
them did, not all of them.
Mhm.
Well, I guess for COVID, they all did this year. So can you tell us about this and about some of these treatments?
Yeah, so there are a number of treatments that we have tried, and basically treatments in sort of, I guess I can say, the olden days now. Again, this is the first pandemic of the era of synthetic biology. Previously, what you did in a pandemic was look at everything that was on the shelf or in advanced development and think about whether it might have an impact on the pandemic at hand. And so that's where remdesivir came from. It was a vaccine, like you said, or sorry, a therapeutic developed for Ebola. I hadn't really had a chance to use it and test it wisely. So that was on the shelf, was subject to clinical trials and approved in the US this spring. Dexamethasone resulted from an effort by actually a group in the United Kingdom running what's called the recovery trial, which took a different approach to clinical trials. Their idea was to keep it simple so that busy hospitals that were facing surges in COVID cases wouldn't have to do a whole lot of extra data collection and everything else to run a trial. So they set it up with very simple data collection, randomization, which is really important for knowing whether it's the treatment or something else,
Mm-hmm.
but done in a way that 20% of the hospitals in England could
Wow.
participate in. And they were able to cycle through a significant number of these sort of off the shelf, potentially beneficial treatments. I would really like us to be able to develop more of that capacity in the US, something else
Yes.
that the philanthropic community could think about. We've got a great NIH effort, the Active Trials and Active Coalition, but those are limited to a relatively small number of typically academic hospitals. And
Yeah.
our pandemic is happening at community hospitals and communities all across the country. And that's where we need to be doing testing. We have the world's leading supply of COVID patients, and only a tiny fraction of 1% of them have been enrolled in a clinical trial. And if you ask the FDA, they tell you that most of the clinical trials that have been done in this pandemic were too small, not focused on good outcome measures, not aligned, not like a good platform like we saw in the United Kingdom to be able to generate answers quickly. So we still have a lot of unanswered questions about the best way to treat seriously ill patients. The treatment I did want to emphasize, though, was the monoclonal antibodies.
Hmm.
So, mentioned President Trump getting the Regeneron combination treatment.
Hmm.
That one's been through a clinical trial, now approved for emergency use. Governor Chris Christie, when he got sick, got the early access to the Lilly a monoclonal antibody treatment. And it's not just you pointing this out. New York Times, I think today, had a big story about Rudy Giuliani maybe also getting access. This is the synthetic biology treatment that's turning out to be quite effective for people who are in early stages of COVID, who are in high risk groups. It doesn't work late, makes sense given what Fred said
What's
before
the
about
name?
by the time you're
Yeah.
hospitalized and having really an overly strong, excessive immune reaction. It's not the virus, it's your immune
Immune.
system. So, not surprising that it doesn't help and might hurt there. But early on, it can make a big difference. The challenge is twofold. One is we don't have as much of these monoclonals as we'd like. We talked before about just this massive early investment effort around vaccines, where there's a huge investment in doing large scale clinical trials with clear guidance from the FDA, and a huge early investment in pre-manufacturing tens of millions of doses of vaccines that we didn't even know were going to work,
Work.
just so we have all of those ready, so there's no delay. Instead of a long linear process, it's a hyper parallel process to get safe and effective vaccines to people as quickly as possible. So, unprecedented there. We didn't do the same thing with monoclonal antibodies. These
Mhm.
also take a while to manufacture. So now we know that they work, but we've only got a limited supply, maybe a million doses or so between now and the end of January. And that might seem like a lot, but when you have 200,000 cases a day, 30-40% of them at least in high risk groups, you can see how that might be hard. It might be hard to get treatment to everyone. The
Mhm.
second problem is, besides having to prioritize and maybe learn better about who's really going to benefit, the second problem is that these monoclonal antibodies require a new way of treating COVID. Previously, up until now, we told people who had mild
Yeah.
symptoms to stay home, stay away from the healthcare system until you get sick enough that you need, help with breathing, or you need to be admitted to the hospital. Now, what we need to be telling those people is, if you are a candidate for a monoclonal antibody and somebody who could be on track to getting worse, you actually need to get into healthcare very fast. And this is a treatment that requires an infusion that takes an hour, and then some monitoring before and after. So it's really several hours, like you do in a chemotherapy infusion clinic at a hospital, except you can't do it in those clinics because you're talking about patients who are actively infectious with COVID. So we're having right now to set up some special infusion clinics, maybe some home-based approaches, bringing some of these treatments to nursing homes, to other underserved communities. And I'm very concerned that if we don't get these new delivery models right and get them implemented across the country, we're going to end up with some real inequities over the next few months in outcomes. These treatments could potentially prevent tens of thousands of hospitalizations between now and February, and be more widely available after that. But we've got to make some big changes in our care models, our payments, and our ways of getting these treatments to patients in a much more timely way.
It, well, that's, yeah, both hopeful but also a real challenge that you're
Yeah.
throwing out there. I want to kind of come back to what you were talking about there, Dr. McClellan, about what happened in England and how quick they were. I mean, what is keeping us in this country from being able to move through clinical trials more quickly in the way that England did? Um, and is that something philanthropy can help with? And I,
I think so.
yeah.
There's been no shortage of philanthropic help in this pandemic in lots of ways, including in supporting research. But I think what we're increasingly learning and increasingly able to do is that with better digital technologies and the ability to capture information on patients electronically, it's much more feasible than it used to be to build platforms for trials. So
Hmm.
this is not a new thing in the pandemic for,
Hmm.
in areas of cancer like I Spy for metastatic breast cancer. With philanthropic support, UCSF, led by Laura Esserman, set up a network of
Yep.
hospitals that could test adjuvant therapies for metastatic breast cancer, and because they had a basic structure in place, even though these were busy hospitals with taking care of seriously ill patients, they could put lots of patients into multi-arm clinical trials, and just cycle through different promising compounds. Do 60 or 70 patients in one, see if there was a response relative to standard of care, the other arms. If there was, maybe increase the enrollment in that arm. This is all following pre-specified rules, so it's sort of good, good clinical practice, and then get to an answer very soon. And in fact, the iSpy network has set up a similar version of that for COVID. iSpy COVID, that's testing sort of phase 2 tests in seriously ill, sort of ICU level patients, of which we have far too many. And they've tried to do it in a simple way where these very busy ICUs can actually use data plus randomization, data that they're collecting in their own hospital systems, without a whole lot of additional work to do randomization. Now, to put that in place at bigger scale, people need to work together. And it's not just a matter of finding an academic center that says they want to do a trial. We had lots of those in this pandemic, and they would start out, and this happened in New York in April and May. They'd start out enrolling. It happened in China. They'd start out enrolling patients, and then because they weren't a broad network, the pandemic evolved in that area. The cases went somewhere else, and they weren't able to complete the study. It wasn't well powered. So this is just really a reminder that for a pandemic, we should have a platform trial system in place, and one that's not a huge amount of work for routine non-academic centers to participate in. And that's not to say we don't need the traditional clinical trials either, where especially for new products that you've never used before, where there's not a good safety record and so forth. Yeah, you probably want to do very detailed data collection, maybe some additional imaging and so forth. It's not part of routine care if you don't really understand the mechanism in practice. But for especially a lot of these treatments that we've used before and just are applying here now, we need a better platform capacity. And this is not true only in COVID or future pandemics, but it also can apply to other conditions where we have drugs available, but we're not using them as effectively as we could. And it would be very helpful to get more information on subgroups of patients. Fred and I have talked about similar kind of platform network for cellular therapies as they're being developed, so we can plug in more and go through these and get more definitive evidence faster. So we haven't really set up the financial supports for that. It's another case that takes good public-private
Yep.
collaboration, but we've got a lot of evidence that it can work, and I hope we can make some more progress.
Yeah. Well, I want to weave in some questions that are coming in from our audience. But just kind of a lightning round to both of you, just as we close out this section on vaccines and on therapeutics. Just kind of on the scientific side alone, lessons learned. What can we take from this experience and we forward with? Whether it's this parallel manufacturing. I mean, what is realistic that we can take from this and power forward? That philanthropy could get behind if it's to change policy, or that philanthropy could get behind a fund. I know you named one, which is these platforms.
Mhm.
Are there any others that we've learned just through this pandemic that you think we could use, for maybe not another pandemic, but just any therapeutic, or for to save a life that is so important.
Fred, do you want to go
I'm glad
first?
to, yeah, we've learned so much, just to lump them again together, I think on the regulatory side, what we've learned to be able to accelerate approvals, reviews, et cetera, from the scientific side, being able to translate some of the basic science to the clinical, to healthcare delivery. This has taught us a lot about that continuum from basic to clinical to health services. And again, from a philanthropy perspective, we fund a lot from philanthropy in all three of those areas. Funding the connection between them is going to be increasingly important to really accelerate our responses to the next pandemic. I don't think anybody uh, is foolish enough to believe we will not have other pandemics. That's the nature of the development of our immune system. It's to constantly go back and forth with various infectious organisms. So there'll be another one. But as Mark said earlier, fortunately, this one has happened here and now where we have so much technology and resources and ability to develop a wide range of therapies. And frankly, I think we're at the beginning of the end here when we're talking about therapeutics. I think the vaccines, we're going to learn a lot from what effectively are phase 4 trials as they're being distributed. And we see what happens in very large, very heterogeneous populations. And we're also going to learn a lot more in terms of therapeutics for these different subgroups in terms of what will be effective, what will be appropriate. Not everybody we know is going to be protected from the vaccine. So what do we do? What do we do for those who are severely infected, as Mark said earlier? And actually, there are a lot of very interesting therapeutics under development that might be effective for various aspects of the disease. So there's a lot yet that's going to happen. We have learned a lot and we'll be able to translate it in terms of diagnostics and therapeutics. I think we've learned also from mistakes. I mean, there have been a reasonable number of mistakes along the way. I'd have to say again, as a diagnostician, to a large extent, some of the early misreads around diagnostics were important. And I don't know, misreads, but maybe miscommunication and uh, not just for the public, but among physicians, and really understanding sensitivity and specificity and how they relate to the prevalence of a disease in a population. So that if you're PCR negative for the COVID test, does that mean you're not infected? Well, there's analytic and biologic sensitivity and specificity, and we've learned a lot. I'm very pleased at how much we really have learned about communication as well. There's still a lot more to do, but communicating effectively
Mm.
to the public about, again, both the diagnostic and the therapeutic side of this. And as we get into the healthcare delivery side, how important that's going to be.
Do,
Yeah,
do,
I would agree with Fred, and just a couple of things to highlight going in the same direction. One is, there are a lot of therapies that could be helpful. We need a better, faster platform that those can plug into at scale, not just now, but for all of these therapies that are coming beyond COVID. The approach that we took for vaccines in this pandemic, I think, has been extremely effective up to this point. We still have all of this distribution and hopefully equitable access still ahead of us. It's going to be really hard work in the coming months. But this idea of parallel process where we have
yeah,
clarity from the regulatory agencies about what's needed to show safety and effectiveness, the capacity to set up large, simple trials. That's what we did for the vaccines. Thankfully, we have more than 100,000 Americans now who have
yeah,
signed up for these trials. They've been simple enough to do in communities all over the country with actually disproportionate representation of people who are older, people who have comorbid conditions, people who are from minority backgrounds. That's new. That's quite an achievement too. And we did the parallel manufacturing.
yeah.
If we had done the same thing for very promising therapeutics, we did it to a small extent, but not really. We wrote a paper back in June pointing out that the monoclonal antibodies looked very promising, but there's only a limited amount of manufacturing capacity. And if we had then started to direct some more, pre-manufacturing some of these monoclonals, maybe advanced manufacturing the other antibody treatments for cancer, for other conditions that also need to be available for life-saving treatment. We could be in a potentially much better place with a significantly lower surge in cases right now and a lot more lives saved. And we definitely didn't do it for diagnostics. Same thing. They're diagnostics that we know work. We started seeing them in March and April, but in terms of really scaling them up, learning how to use them for not just for people with symptoms, but for repeat screening. I think we missed on that one too. And then the last thing is our healthcare payment system is mainly based on fee for service, and that was really a disaster for healthcare organizations. At the time when we needed them to be responding, their revenues were dropping 30, 40%. They were laying off staff and trying to reopen important services. But what they really need to do was, really redirect towards telehealth, virtual care, using data to predict who is going to be at risk, connecting with public health. And to do that, you need different payment models, payments that have more flexibility, so-called value-based payments like accountable care organizations. Those organizations have done remarkably well in the pandemic. They've been financially stable. They've been, they were already implementing telehealth and tracking their high-risk patients, and they're all ready to go to vaccinate all of their elderly and other at-risk individuals. They know who they are, they know where they are, they know how to reach them, they know how to engage them. That's the kind of healthcare system we need for the future too.
Yeah, we have a lot to do on the health, but I mean that's a huge message of hope that you're delivering about all these strategies that this pandemic has uncovered, and that we can study them, and philanthropists can look at them, and you can take any disease that you want to fight, and you can take some of these strategies and apply them, and you can have a much better and much faster outcome. We have got so many questions coming in now. They're
Yeah.
all streaming in. Let's kind of do a lightning round and kind of work through these questions. I'm going to start with this one. Why is no one talking about herd immunity if so many people are asymptomatic? Is there any more information on how long immunity might last, as reports are all over the place?
So
Two
we
questions.
have a huge number of infected people who have been infected in this country. By official count, 15.5 million. I think the best estimates are that the true count is probably 4 or 5 times that high. But that gets you to about maybe 60 million, which is still far from herd immunity. And the countries that, like Sweden, that have tried to get at this through herd immunity have ended up having to move back to really lockdowns and the like. So we're not there yet. This will mean we don't need to get 70% of the population vaccinated to have a good level of protection. But we still are a ways away from herd immunity in most places, even very hard hit areas of the country. We don't know how long immunity lasts. It does seem like it might not be as strong for people who had milder cases. If you had a mild case, definitely the recommendations are to go ahead and get vaccinated. So hopefully we're obviously over time we're going to learn more about how long immunity lasts, and everybody should be thinking about vaccination.
I'm going to direct this one to you, Dr. Sanfilippo. What strategies or solutions can work to keep 90 plus million high risk Americans safe between now and when they can get vaccinated?
Well, again, I think avoiding the risk of being infected is the key one, for sure. And if you think you have signs or symptoms, to access healthcare, because the earlier the intervention, we have some therapies that are a bit more effective, the better. I know for a good period of time, the message was avoid the healthcare system because it was potentially a risk. So I think those are the two major ones for folks who are in that high risk category, and to be aware of it as well. And I think also, it varies individual to individual. Others should be sensitive to being around individuals at high risk. I know there's a sense that once you maybe test negative, and again, we know there are a lot of false negative tests that are out there. Have to be careful about that. It's great on a population base, but when you're talking about an individual determining your risk, I've always said you need to be fully informed, and you have to realize what some of the exceptions are. So, and even folks, there are certainly several case reports and understood well that folks who have been infected and have become immunized are still potentially at risk for being infected. That's very, very, very low, but still is that potential. This virus does mutate a small bit, but it can. So I think it depends what your risk category is and how you personally want to weigh the isolation, so to speak, the mask and protecting yourself versus getting on with your life, so to speak. And that's been the big challenge for individuals and the country as a whole.
Um, Dr. McClellan, why have they not approved vaccines and treatments for children? Are there some concerns for teens and youth? This was a question from our audience.
Yeah, so the vaccine trials that we've just been talking about were all done essentially in adults, and there are a couple of reasons for that. One is that kids themselves don't have, no, typically, fortunately, don't have very low rates of serious complications, and the other is that, as we've talked about, the highest priority groups for vaccination were going to be older individuals, frontline workers anyway, not kids. So the idea was to get evidence and experience in those groups first. Pfizer has started doing studies in at least older kids. There will be studies as we head into 2021 after we see the vaccines work and can build on all that evidence. There will be studies in children. Probably is going to take some reformulation of the vaccines given smaller size and all of that. And they may not go all the way to showing that that children have lower rates of infection and the like. That'll be harder to show by March or April, hopefully. So we'll look for like immune response in the kids, make sure there are no side effects. So there will be vaccination in children, but that's still a ways off. Summer next fall.
Another question, Dr. Sanfilippo, you may have addressed this partially, but what is the status of antibody testing to see who has already recovered? It seems like that didn't work.
Well, no, it does to some extent. If you've generated antibodies against the virus, and again, there are a variety of epitopes that can be recognized, antigens be recognized. That correlates very well with your immunity. You're having been exposed, mounted an immune response. The antibodies that are that specific don't just happen. You really have to mount antibody response. Um, that's associated with a pretty good degree of protection. The question is what levels, how they wane, if you're exposed to another variant. Those are the mitigating factors relative to if you have an antibody detected after the response, are you really immune and are you really non-infectious? And when you get into down really inside baseball, it depends what antibody. I mean, there are different classes of antibodies, subclasses of antibodies. They have different avidities or binding sites. So again, it's a very complicated system. We can generalize across populations. When you get into individuals, there are always exceptions to that general rule.
Well, this time has just flown by, and I could continue to ask questions for hours, but I just want to stop now and thank you for your time, Dr. Sanfilippo and Dr. McClellan. We are just so privileged to have you with us here today. We know you're in great demand. And I also want to talk to our philanthropists and audience and say we hope this session has really informed your philanthropy, and we're here to provide follow-up information for any additional questions. Beyond that, I really want to encourage you to hang in there, to stay safe, and when the time comes, go get your vaccine. Thank you to everyone.
Thank you.
Thanks.